This podcast will provide a brief overview of neural tube defects. After viewing this podcast, you should be able to describe the embryologic origins of neural tube defects, understand when to suspect a neural tube defect, understand genetic clinical presentations of myelomeningoceles, list the complications of myelomeningocele including mobility impairment, neurogenic bladder, and hydrocephalus, and counsel families on the role of folate supplementation to reduce the risk of neural tube defects. Neural tube defects represent a failure of neural tube closure during primary neurulation and can result in exposed segments of neural tissue, either brain tissue or spinal cord and/or nerves. A subset of neural tube defects are spinal dysraphisms, which is an umbrella term that encompasses all forms of spina bifida, which can either be open or closed. Spina bifida is when the spine fails to close, meaning the pedicles and/or laminae are splayed. Neural tube defects of the spine can be closed spinal lesions with or without cutaneous manifestations, or they can be open spinal lesions in which the neural elements are exposed to the environment. Neural tube defects occur in 1 per 1,000 live births, and spina bifida occurs in 1 to 3 per 10,000 live births. Spina bifida occulta occurs when the laminae fail to develop, but the spinal dura and skin develop normally, which results in a defect hidden under the skin, making most individuals unaware that they have the condition. Meningocele occurs when the laminae fail to develop, resulting in a sac of CSF fluid extending outside the spine. Lipomyelomeningocele is a neural tube defect where the neural elements are interspersed within the lipoma that typically extends deep, that is, down to the level of the spinal cord or cauda equina. Myelomeningocele is caused by the failure of separation of the neuroectoderm and cutaneous ectoderm during the neural tube closure process. It results in absence of the spinous processes, laminae, and overlying skin, so the neural tissue, known as the neural placode, is dorsally exposed, as we can see in this schematic here. The diagnosis of an open neural tube defect is easy to make because it is visually apparent after birth and sometimes visible in utero on routine ultrasound scans. However, with a closed neural tube defect, we can use clinical findings that sometimes raise its suspicion. The more obvious cutaneous stigmata associated with neural tube defects include a hairy patch, also known as tuft of hair, a sacral dimple, hemangioma, or lipoma over the spine. These findings are concerning when they are above the gluteal cleft and sometimes lateral to the midline. Orthopedic abnormalities such as talipes equinovarus, also known as clubfoot, can also be present at birth in patients with neural tube defects. Changes in motor skills including new onset or worsening weakness, walking pattern changes such as toe walking or waddling gait, loss of previously acquired motor milestones, and asymmetry in motor function can all raise suspicion for an underlying spinal pathology. Enuresis, which is urinary incontinence in a child, can also raise suspicion for a neural tube defect when primary enuresis persists beyond the age of toilet training, or secondary enuresis occurs where a child who has previously been dry starts wetting again. Enuresis that is refractory to conventional behavioral and medical treatments, particularly if it is severe or associated with urinary urgency, frequency, or retention, can also be concerning for a neural tube defect. With these clinical signs and symptoms, it's important to differentiate between common developmental issues, however, and as a symptom of an underlying neural tube defect. It's important to consider the child's overall clinical picture, their other findings that might point to the underlying neural tube defect instead of basing the diagnosis on one symptom alone. The general clinical presentation of myelomeningocele can vary widely depending on the level of the lesion, the size of the defect, and associated anomalies. Generally, myelomeningocele can be detected in utero on routine prenatal ultrasound scans and at birth given its obvious morphological manifestation on a newborn's back. The general clinical findings of a myelomeningocele include neurological deficits. The level of spinal defect typically correlates with the neurological deficits observed. Lesions higher on the spinal column tend to result in more severe motor and sensory deficits, patients may present with partial or complete paralysis below the level of the lesion, muscle weakness, loss of sensation, all resulting in overall mobility impairment. Hydrocephalus is another general clinical feature. Hydrocephalus is increased CSF in the ventricular spaces of the brain, which occurs in 80 to 90% of children with myelomeningocele, and 70 to 90% of these children eventually require surgical treatment of myelomeningocele-associated hydrocephalus. This is because myelomeningocele is associated with another entity called Chiari-2 malformation, which is the downward herniation of the medulla and midline cerebellar structures called the tonsils past the foramen magnum. All of this results in obstruction of CSF flow. This may manifest as an enlarged head circumference, bulging fontanelle, and of severe symptoms of increased intracranial pressure such as vomiting, lethargy, and irritability. Orthopedic issues include deformities such as clubfoot, hip dislocation, and scoliosis. All are common in patients with myelomeningocele due to imbalances in muscle strength and structure. Neurogenic bladder is another complication due to the disruption of sacral spinal nerve roots that are involved in the neural placode. Neurogenic bladder refers to bladder dysfunction in the form of a spastic or hyperreflexive bladder, which is characterized by uninhibited contractions causing urgency, frequency, and urge incontinence, or in the form of a flaccid or areflexive bladder characterized by urinary retention and overflow incontinence. This can lead to urinary tract infections and potentially renal damage. While intelligence can be normal, some individuals with myelomeningocele may experience learning disabilities, attention deficits, and executive function difficulties in life. Folate, or vitamin B9, is a particularly important molecule in preventing neural tube defects. Periconceptional folate reduces both the incidence of neural tube defects among women who have not previously had an infant with a neural tube defect and recurrences among those with a previously affected pregnancy. Folate is an over-the-counter supplementary product that can be taken around the time of conception and continue through to the end of pregnancy or until the end of breastfeeding for the baby. The usual dose of folate is 0.4 milligrams daily for those who have not previously had an infant. Folate's role in reducing the risk of development of neural tube defects has been established since the early 1900s. Multiple international cohort studies and task forces have supported the role of folate supplementation in pregnancy, and some countries have even mandated government policies for food fortification with folate. In summary, spina bifida is a type of neural tube defect caused by failure of closure of the posterior neural tube during neurulation. It can result in spina bifida occulta, meningocele, lipomyelomeningocele, and myelomeningocele. There are certain cues to investigate for an underlying neural tube defect, including cutaneous stigmata, changes in mobility, and secondary enuresis. Myelomeningocele typically presents with hydrocephalus from Chiari-2 malformation, which involves downward herniation of the cerebellar tonsils and medulla. They can also develop talipes equinovarus and neurogenic bladder. Folic acid has been shown to prevent occurrence of neural tube defect.